The Over the Bonnet podcast is brought to you by Merrimark Medical, Gympie Foam and Rubber and Nikat Earth Moving. My guest today is one of the world's best in thoracic surgery, Dr Jhao Fengrui, who has made a career as China's leading lung transplant specialist. Dr Zhao also pioneered the development of Zhao's artificial trachea, and since his retirement, he's been working to pass on his knowledge of tracheal reconstruction.
Over the Bonnet with Mark Piepers.
Well, at least the guests are good. You'll never know what happens with the conversation when it's over the bonnet.
You're kidding me, aren't you?
Zhao Fengrui?
Yes.
Welcome to Over the Bonnet.
Okay.
So, tell me, you are a transplant surgeon. It's an amazing thing that you've achieved. Let's go back to the first lung transplant you did. Can you tell us about it?
I performed the first lung transplantation in China. That is in 1996. In the history of lung transplantation, started in 1960s, early 1960s in U.S., but not quite a success. After this, a lot of doctors all over the world tried this lung transplantation. Several cases, not quite a success. Then this work stopped for many years.
You were saying that they weren't a success. What actually wasn't right about the early lung transplantation?
Early lung transplantation, because the technique is no problem, but the immune drug is not quite good. So patient, the rejection is severe. So usually the surgery is a success. But after the surgery, the rejection is severe. So eventually a patient died short after the operation. They're not quite a success, of course. Then stopped all over the world. This work stopped so many years.
So what was done about the drug? What changed about the drugs that were used to suppress the immune system from rejecting the lung?
Nowadays, we use a very powerful drug.
When the patient comes in needing a lung transplant, what actually happens?
The patient usually with end-stage lung disease, usually the respiratory failure happened. Very difficult for their breath. Usually need oxygen all the time, and the people only can usually stay on bed, cannot walk around the house. So very end of the disease, very severe situation. The second, you need a donor. Where you can get lung to transfer to this patient. In China, the best is from a relative, from another brain dead people. You get a donor. When you have a donor, you can receive a patient. If you no donor, you cannot receive this patient.
How difficult is it to get a donor that is compatible with someone that needs a lung transplant?
Difficult. You must do this compatibility test first. When they agree each other, you can do this operation. The operation is, of course, not an easy job. You have to reconnect the trachea, reconnect the big blood vessel, even pericardial. And after this operation, patients still have a lot of problem like rejection and infection. So you have to take intensive care for this patient. But we checked the sputum and found the pathogen. Then we used the effective drug to the patient.
You talk about back in the 60s that it wasn't very successful, but the transplants, when did they start becoming successful?
In 1979, Dr. Cooper, at that time Dr. Jhao Cooper, he was in Toronto General Hospital. He is the director of thoracic surgery. He started his work again, and he has never stopped the research work after 1960 lung transplantation. But in 1979, he started again, and the first case patient successful, lived more than 5 years. And in 1980, 5 years later, he published an article. So all over the world knows about this successful lung transplantation. Then they encourage all thoracic surgeons to try this lung transplantation again in early 1980s. At that time, I was in Northwestern Medical School. Dr. Joseph Losesero, Dr. Losesero performed several cases, and with success. And I learned this technique from there. Later, from Jody Cooper, I invited Cooper, Dr. Cooper, to China, visited China twice, and gave us a very, very excellent lecture, and transfer this technique to our Chinese people.
Are there many transplant surgeons in China?
Not too many. Not because nowadays the donor is the big problem.
Now, you were doing some study, you were talking about the US, you've done work over there. So tell us about the work you also did in the United Kingdom.
After I studied in US 2 years, 1989. 1989, I back to China. 5 years later, 1993 to 1994, I went to UK and started in Harefield Hospital, close to London. One of the 2 transplant centers in UK. One is Cambridge University. Another transplant center is Harefield. Harefield has a famous professor, the only professor in that hospital, named Professor Sir Mark Diakub, because he is Sir. King Elizabeth gave his award, Sir.
So he was knighted for his work in the surgical area.
Yes, very, very famous doctor all over the world. He performed the largest series cardiac transplant. When I was there, he transplanted heart is over 1,000 cases already, and he performed more than 300 lung transplantation as well. And the number of lung transplantation even equal or a little over Dr. Cooper did at that time. And he transplanted lung and heart and liver together.
Wow.
And he invented Domino Transplantation. So he is quite famous.
This Domino Transplantation, tell us about that.
You transplant heart lung for next patient. But next patient, perhaps heart is very good. Lung is with disease. So they transplant heart lung, give this patient, then you can get a good heart. Transplant this heart to other person.
Okay.
So domino. You like a domino.
That's amazing. It's
amazing.
It's really, when you think about when Christian Barnard did the first heart transplant back in the 60s, we've really come a long way. What do you think about how far we've come? Does it amaze you? Because you've been involved at it at the coalface.
The improvement is quite big. During early stage, we anastomosed only trachea and pulmonary artery, pulmonary vein. Sometimes not use the artery, the pulmonary vein. We connect pulmonary vein, so that's easier. But later we reanastomosed bronchial artery. That make the successful rate much higher. But the technique, of course, much more complicated.
How long do these surgeries take?
Usually 1 hour around this.
Really, that quick?
Just for this anastomosis, not for whole operation. Whole operation include anesthesia, include close the chest and everything. The main procedure, 1 hour around that. Sometimes a difficult case need several hours, some even more than 4 or 5 hours, because you need resect the diseased lung first. That costs a lot of time.
How hard is it on you as the surgeon to be doing these heart-lung transplants? How much pressure is on you?
That's a big problem, a big question. Especially in China, many years before, the most donor you must find, but difficult. At that time we don't have a brain death rule. The only donor resources is criminal. So when they executed, we harvested this organ, but later was forbidden, and nowadays we changed to brain death. But in China, because the tradition, people don't like to give organ to others. So nowadays is the big problem to find a donor.
So why is it so difficult to find donors? Why aren't people donating their organs once they pass?
When people became brain death, before that, or after that, relatives, or before that, the patient themselves can give this informed consent and agree with donation. That's no problem.
What about, as you say, back in the early days, using criminals as donors?
Yeah.
How did that work?
Brain death organ is much better. But a dead organ, after people died, then you harvest this organ is not quite good, but it works. Nowadays, because lack of a donor, every center of this transplantation use dead donor organ as well. People, of course, like brain death or donor organ. But if you don't have this, that organ is okay. But must very fresh. Usually after people ejected, immediately we need to open the chest and get the organ out. I know that I usually just perform lung transplantation. I'm not to harvest organ, but I know that usually the doctors use the sterilization is quite easy, simple. Just spray the iodine on the body, then quickly open the chest and get the organ. Or if you like, you need more, you get liver, heart, and lung, even kidney together. So that's a quick job.
When you started, do you remember the first time you did the whole lung transplant?
Yes, lung transplant, single lung transplant. For me, they said I'm perform this operation very friendly, like I already done many cases. Because before I did this, I prepared myself for many years. So every procedure in detail, I remember clearly. So I performed this operation very smoothly.
Once the procedure became better and the drugs became better, what sort of life expectancy are these lung transplant recipients? How long are they expected to live?
Usually, we expect them live more than 5 years. That's the best. But early stage, only 1 to 3 years. Not because the drug is not quite good, not like today. Today is patient can live many years, even lifelong.
Okay. What's the quality of life for them once they've got the new lung?
Like a normal person, patient even can do exercise. They can climb a mountain. They can swim in seawater. So normal life, live a normal life. But before this, totally disabled.
Let's go back to the start when you became a surgeon. Tell us about medical school. What happened back then?
We learn Western medicine, not the traditional Chinese medicine. So medical school almost equal to Western country. What in Western country? We learn more than 40 or 50 different lessons. From the basic to clinical.
You talk about traditional Chinese medicine. Did you do any study in that as well?
Yes, only 1 year.
So what did you learn in that you bring across to, say, your transplant surgery and your thoracic surgery that you were doing? What traditional Chinese medicine do you use in, say, the more traditional surgery?
Not use very well because different system. We can use Chinese medicine in not severe cases. For some patient, the Western medicine cannot have enough effect. We give them some Chinese medicine as well to some, I think sometimes better than placebo.
Do you think that that Western medicine should be adopting some forms of Chinese medicine?
Yes, I believe that, because nowadays even Western medicine not can treat old disease. When they fail to play that role, you have to look for alternative medicine. So Chinese medicine should be an alternative medicine. Even in India, Egypt, and in China, Tibetan. So people have disease need to be treated and get better quickly. If only Western medicine sometimes doesn't work, so you have to look for others.
What would you say would be the principal difference between Western medicine and traditional Chinese medicine?
Traditional Chinese medicine very difficult to repeat, redo. Different doctors, they can give you a different medicine, but all of them is Chinese medicine. You give this, I give that one. But the effect is the same. But Chinese, Western medicine is same drug given to different people. The action is the same. So that's quite different. Even the theory, not Chinese medicine, the theory is sometimes very difficult to totally understand. They say some yin, yang, and negative, and positive.
Let's just run through the 5 points of traditional Chinese medicine.
Mm-hmm. Metal, wood, water, fire, and soil. Fire means in China is 五行. Yin Yang Wu Xing is the basic theory of Chinese medicine.
So how does that help the patient when you incorporate both?
In my hospital, China-Japan Friendship Hospital, we have a Western medicine department, and we have traditional Chinese medicine department as well. They work sometimes together. If they have some difficult case, they can discuss together and give them cooperative treatment.
Is that a better way of doing it?
Sometimes it works.
So let's go back to when you did start at medical school. What got you into it in the first place? Why did you want to get into medicine?
Oh, that's because doctor is very respectable profession. So people like to be a doctor at that time, not today. Today is a terrible job because a lot of rejection, a lot of prosecution. Very difficult to be a good doctor in China nowadays.
So what happened when you first became a doctor, when you graduated? What happened then? Where did you go?
I graduated from the most famous medical university in China, Beijing University Medical School. In 1967, I graduated from. But at that time, no doctor degree, only graduated. That was Cultural Revolution period. Everybody was sent to, graduated medical student, sent to countryside. Not because Chairman Mao, the health leader of China at that time, Chairman Mao Zedong, he said, "Oh, you're a young student, need to go to countryside, go to factory. You need to be re-educated by workers, by farmers, by soldiers. You are young, you should go there. So the first reason. Second is my father suffered a lot at that time because he was a vice president of Japanese bank before 1945. In 1967 or 68, at that time, Cultural Revolution happened. Then he became anti-revolutionary. Then was sent to labor camp.
Your father was sent to a labor camp?
Yes, so suffered a lot. Of course, in this kind of family, I couldn't go to a big hospital. I was sent to far away from Beijing, 2,000 kilometers far away from Beijing, 3,000 kilometers far away from my hometown, home city, northwestern mountain area, rural area, very poor, and sent me there. And first, you must be a farmer in village and doing farmer's work 1 year.
So you've graduated from university.
Then sat down to the countryside and work as a farmer 1 year.
Was that hard to do?
Every kind of farmer's work. We grew crops. We cut the grass. We do a heavy labor work every day for 1 year. Then, because I will try to be a hard worker, and they are satisfied with my work. Then they ask me, then send me to a military hospital, a big hospital in that area, more than several hundred beds, and this equipment is good. So I learned medicine for half a year again. I got some basic knowledge as well. Then back to send me to county hospital, not the smallest, but with around 30 staff there. Of course, still a very small hospital.
You must have, though, been so happy to be away from farm work to be doing what you really are meant to be doing.
Yes. I'm very gratified, happy. Eventually, I became a doctor.
Talk about this early stage at the hospital. 30 staff. Are you the only doctor, or how many doctors are on board?
At first, I'm the only surgeons in this hospital. Later, 2 or 3 other younger graduated students assigned to this hospital again to be a surgeon. But I am the oldest, so I have to do everything, every patient I have to deal with.
Talk about the first time you did surgery.
Oh, that's very, very funny, because later I am quite interested in tracheal surgery. The first surgery is thoracotomy. I do a surgical procedure on a trachea. When I was assigned to return to this county hospital, not more than 1 month, when I was at a night shift, in early morning, came old lady, over 70s, a small lady, and she was suffocated several times during the road. Sending her to hospital on the road, she suffocated several times. And I checked her. I know he has throat spasm. You must cut the trachea first, but I never did that. I quickly reviewed the book and let her lay down on the table. But when she lay down on the table, this spasm happened suddenly. A patient breath stopped. The colors of purple lip changed to purple. I'm afraid that she died on the table, so I grasped a knife just on the middle line and put a hole into the trachea without anesthesia.
Wow.
Yeah, because a terrible emergency. Otherwise, the patient died. And then insert a small tube into trachea. Pull the high pressure air from this hole came out, and patient breath returned. And with this small tube, I saved this old lady. And she's already in coma, and nothing painful. She's quite happy. Later, I know he has a severe disease, infectious disease, and changed the nerve, influenced the laryngeal nerve. Then this spasm happened.
So you're doing this surgery, it's the first time you're actually doing it from a book?
Yes. And sometimes I from doing other operation also from book, because I'm the only surgeon in this hospital. I have no supervisor, no even attending doctor. I'm the oldest general surgery doctor there. So once a patient, after during the operation, I do know this patient need to do a Roxway anastomosis between intestine and stomach. I just know this concept, but I don't know how to do this. I ask my colleague take a book and open the book and read the operating procedure for me. I just follow him and doing this procedure. And of course, eventually the operation is a success. We teach ourselves.
It's pretty amazing, though, that you're doing that. How often did that happen?
Not quite often, but several times. Usually, when sometimes you can quite a rare disease. You have no enough experience. You have to look for the book. If before operation you know very difficult, you can read the book first. Sometimes a special situation happen during the operation, and you cannot you were not familiar with the procedure. So in that case, we need somebody read book and give you a help.
Did you actually have someone sitting there with the book, holding it and showing you while you're doing the surgery?
Someone, my colleagues, get the book and open the book, find the operating procedure. He read the procedure. I follow this procedure to do the operation. That's the way I treat the patient. And sometimes you need this because you have no enough experience with the surgical procedure.
What did the people holding the book, did it surprise them what you were doing?
No, because everybody knows I'm the only experienced doctor. No others can do this operation. If you don't do operation for this patient will die. In northwest China, a county is very huge. Some the area of this county more than 100 miles square mile, and only one county hospital. So patient came to a county hospital. Some patient very far away from their home village, more than 100 kilometers away. If with severe disease, sometimes died on the road. Sometimes when they even when they not severe enough, patient goes through this long way. After that, the situation is very bad, and usually in emergency situation.
So often they would die on the way to hospital.
Yes, sometimes they died before hospital, and so every patient comes when you check them, always in a very severe situation. You must do something for them immediately. The time is life. We say that usually like that. Every year, I'm a surgeon, but you know only not more than 30 staff in the hospital. Doctor not more than 10. I'm the only surgeon. I have to do all the job when we on night shift. Night shift only one doctor, one nurse. No matter what kind of patient come to your hospital, this doctor, this nurse should treat them. Even the patient is a pediatric, gynecologist, a gynecology patient, some even deliver baby, even infectious disease, anything, any kind of disease you must treat. So I can say at that time I'm a very, very good general practitioner. I treat a lot of difficult labor mothers. I can do. I performed many cesarean section procedure. I deal with the bone structure. I resected even the kidney. That belongs to urology, not my job, but I have to do. Because if you don't do this for them, they will die. So I learned this sometimes from book, immediately before operation.
Wow, and the book was still open during the operation?
Yeah, no. Sometimes when you know that you don't need to open that again. And equipment in county hospital at that time is very simple. Only a simple X-ray, and we can do some simple chemo exam. we can check the blood cell count, check some blood, very simple equipment. Or we don't have ultrasound at that time. We have no CT, of course, only a simple X-ray machine.
Do you find that because you had to be such an all-round general surgeon in so many areas, it helped you later on?
Yes. This kind of work, we can do everything, every specialty procedure. That give me a lot of knowledge about because the medical knowledge usually they help each other.
When you got into thoracic surgery and you're talking about lung transplants, what got you interested in that in the first place?
After these 10 years in rural area, the Cultural Revolution stopped, and China education system returned. I passed national examination to be a postgraduate, and I start to learn thoracic surgery. Because in the county hospital, we don't have the good method the good anesthetic method.
You say you were 10 years in the county hospital up in the northwest. Did you want to leave, or did you have to stay there?
I have to stay there. That is because government send you there. You cannot go any other places, other hospital. No, you just stay there. If Cultural Revolution not stopped, and you stay there all your life, your lifelong there. You cannot move to other places.
What did you think about that? Can you talk about that?
Yes, we of course feel some, in some extent we feel miserable. Yeah, and at that time a very difficult situation, international situation, all China against Russia at that time. They have some conflict around the border. And far away, I stay far away from my hometown. I think if I stay in this county hospital, why I couldn't back to my hometown and stay in my hometown, even a county hospital, that's close to my family.
Did you miss them?
Of course. I'm quite young at that time, so usually we miss my family, but you cannot do, you can do nothing. You have to, every year, you have to take a long journey back to your home, and it costs you big money. Because only a small salary for us, we save every penny for this long journey. Every year, one time, back to hometown, see my mother, father, and sister, and brother. And only we don't take a rest even weekend, and we got the time together and take this trip.
Were they proud of you?
Yes, they proud of me because I'm a doctor. They know I save people's life.
Once the Cultural Revolution ended,
in 1976,
what happened then?
After that, the education system returned, and university opened again, school opened again. Before that, school closed. university closed.
Once you were able to go back to study again, what happened then?
Yes, I started thoracic surgery for 3 years. Good enough, my teacher is most famous, the first generation Chinese thoracic surgeon, very famous. Today still alive, over 100 years years old already.
Wow.
Yeah, in my hospital. My teacher is a very good teacher. I'm quite lucky. I have 3 most famous thoracic surgeon as my teacher. First is this Chinese teacher, very famous in China. And I even learn this lung transplantation. I do experimental work on top to lung transplantation. And another topic is artificial trachea. You see, trachea again. Artificial trachea. Why I researched this topic? That because my teacher at that time bought a naval trachea. Naval trachea is the only commercial trachea. So my teacher bought one, cost almost $1,000 US. And he asked me to do more research work and like this naval artificial trachea.
You started developing your own special trachea. What happened then?
I mimicked this, and I found some engineering expert. They helped me get some silicon tube.
Because the normal trachea, when they just put a tube in, that's not very successful. Is that correct?
Yes, not quite a success, but that is the only commercial artificial trachea. And at that time, people believe this trachea is the best. You can use clinically. But eventually, nowadays, very few people use it clinically. So today, we can say all the artificial trachea are not success. All the artificial trachea before me totally failed to clinically use. At that time, I just mimicked this naval artificial trachea to create my artificial trachea, but eventually failed to do that. I use a lot of different material, different design, and several months, not more than 1 year later, I found all of them didn't work. Because non-organic material cannot heal with the human cell. And that all this, because the shape like a tube, the inner side, no protective lining. Usually people's trachea, the inner side is membrane, not protect trachea from infect bacteria. But artificial material opened to air, to outside world. And the air is not 100% clean. Sometimes with bacteria, with pathogen, of course, infection happened.
You were looking at these problems. What did you find and what solution did you come up with?
You must use mesh design. Because this mesh with a lot of hole, the human being tissue can penetrate this through the hole and join together, glue together. But this mesh is sheet-like. You think about that. If you roll up, curve up this sheet-like mesh and suture them together, that is a tube. Okay. A new, of course, formed a tube-like. That's a very, very good idea. Suddenly, I feel so exciting. I got it. We need to do experimental work first. So we organized this research work immediately after that. And eventually, after 2 years experimental work, I used 50 dogs and different. I divided them to different groups, different shape, different material, different design, and after this experimental work, the artificial trachea got success. My design is totally different from the others.
So how is it different, and how do you get the skin to grow through this mesh?
The design is tube-like, no protective lining inside, no blood supply, not an organic organ, no, not a living thing. My artificial trachea nowadays they called Zhao, because I'm a Jhao Fengrui. They call this Zhao's artificial trachea. My design is a sheet-like mesh, alloy mesh. We use this alloy mesh as the stent. I use it it has elasticity. They has hardness. When you make a tube, use this mesh, you can bend it, you can twist it, you can stretch it, just like trachea. We put this mesh under the skin, under the endothelium, under the membrane, and several weeks later, the subcutaneous tissue join the skin tissue, membrane tissue, endothelial tissue. They are joined together through this hole and became integrated things. After this finished, we cut the skin or membrane along with this mesh for border. Cut through this. Then dissect under the mesh between cutaneous tissue, subcutaneous tissue, and muscle. Dissect them. Leave the middle 1/3 intact. You don't need to dissect there. That be blood supply. Then you roll up this, curl up this mesh and suture them together. Then a tube formed. This tube inside is protective lining, skin or membrane. And the outside is cutaneous, subcutaneous tissue, connective tissue. Between is this alloy mesh. The alloy mesh gave the shape, gave the hardness, gave the elasticity, and prevent from this artificial trachea from collapse.
So you've now got Zhao's artificial trachea. Talk about the first patient that you put it into.
She suffered from cyst adenocarcinoma more than 6 years already, and treated many times, even radiotherapy and endoscopic laser treatment many times, and always the disease recurrent. This time the disease recurrent, and tracheal lumen already obstructed more than 70%. Patient cannot lay down, just sit straight, and short breath and difficult breath, strider, heavy strider, and sometimes feel suffocated. And she looked for many big hospital in big cities, for example, Shanghai, Beijing, Wuhan, Zhengzhou, and see many doctors, experienced doctors, famous doctors. I can see many. But they all refused to do this operation because the tumor is too large, already more than 4.5 centimeters, the longest diameter, and obstructed the trachea too much. And when they came to me, the first patient, I have not confidence. I talked to her. What I already did is experimental work. I did this, but I think it's successful. You can take your estimate. If you believe me, I do this operation for you. If you don't believe, I don't touch you. Very difficult operation, dangerous operation. She don't start. Eventually, she says, I believe you. Even her husband, they said, we already see so many doctors in the hospital. We know the severe situation, bad situation. You don't do operation for her, for my wife, she will die not a long time later.
So what happened?
So she agreed, but I'm still not quite satisfied with this. I organized a consultant group consultation in China, in my hospital, and many experts in different specialty attend this consultation. They are all, I report to them my work, and they are all believe this artificial trachea can use clinically. And the patient get informed consent. I prepare to do this operation. End of the 2001, I do first, because after I prepare this memory alloyed mesh, you need to prepare this first. You cannot buy this. You must ask somebody made this mesh for you. So after I prepare this, I perform the first stage operation for her. I cut skin, neck skin, and embedded this mesh under her neck skin for 3 weeks. Then I like to do the second stage operation, but this time something happened for me. Not good. I think it's an ugly thing. At that time, I'm not the director. I was the vice director of my department. I still have a director above me, but this director says rumor, not say to me, just give some rumor outside. This he said they didn't publish any article concerned with this artificial trachea. Even experimental work didn't publish any journal. I don't think he can success do this operation. This operation is a test. It's not a good thing. Human test. I feel so sad. But I talked to the patient. No good to do operation for you anymore. If success, of course, no problem. If with some bad results, I cannot accept this. I think I gave you some money, and I put this mesh out of your body and finish all the things. I couldn't do operation for you furthermore. But this patient very, very stubborn. She said, "Oh, I can't waiting for you. And if you don't do an operation, I will die. I believe you. I trust you. No matter what result, even died." Her husband said, "We thank you. We are not give you any trouble." I couldn't take off the mesh, so she back to their hometown. 1,700 kilometers away from Beijing, in Henan province, a village. The time passed. April, early April, I have an international conference held in another city close to her village. In that city, I hold this conference, and she came to me. This time, you come to my province, you can do this operation for me. And I think this is far away from Beijing. I can do this operation secretly. Nobody knows. So that's easier. Good or bad, they cannot say anything bad words to me.
So what happened?
So I took my student together with 2 people, came from that city to her hospital, to her county hospital. Very small hospital with a bad environment and equipment. They only have a very simple anesthesia machine, not ventilation, only air bulb. You have to press air bulb and keep patient breath. That's a very, very original method. And even the operating room, the door is broken and cannot close tightly. But I think this is a good place because far away from that director. So I performed the operation for her, totally 6 hours. I resect 6 centimeters long trachea. That's the limit, the biggest limit. Even Dr. Grayler says almost a half trachea long. So I resect a 6 centimeters disease trachea and use 5 centimeter artificial trachea and reconstruct trachea.
How did it go?
Yes, very, very good result. And for prevention, something happened immediately after this operation. I do thoracotomy below the lowest position. I do thoracotomy. The 1 week later, we don't take off the endotracheal tube, and 1 week later, and 18 days after the 18 post-operation day, patient discharged. The second day after the operation, she already go around the hospital and can have a normal food.
How did it make you feel?
Oh, feel very good, just like normal people. The breath is very smoothly, and not too, because the operation only on neck, not quite painful. This is my first patient, a 48 female farmer. This is 3 months later after the operation. She can perform hard work, farm's work, all the very heavy work she can do.
It's pretty amazing that you've been a transplant surgeon. You've invented Zhao's artificial trachea. You've retired now. What's in the future for you?
I like Australia because this pandemic. I stay Australia already more than 11 months. I know Australia furthermore. I visit Australia several times. I like this country, but this time is the longest time. I know much about Australia. So big country, so small population, only 26, a little more than that billion people. Compared with China, 1.4 billion people, 50-fold. Everywhere is people. You have get noisy. I like here, very quiet, people friendly, very, very good air, good wind, very clean wind, very, very good water. And everywhere is a lot of forest, grassland, and very, very no pollution, very, very good place for even for especially for retired people.
So the knowledge that you got, how are you going to use it now? If you do stay in Australia, how are you going to use the knowledge that you've got?
If I stay here, I'm quite healthy. I have no any disease. Nowadays I stay in my friend home. I do gardening every day. I like to do work. And I still have some cooperative work with my colleagues, my students, and even other hospitals beside Beijing. During last 2 years, I retired, but I still do some consult operation outside Beijing. I visit more than 100 cities. Big cities, 100 big top-level hospitals. I gave them lecture there. I perform a consult operation there. Even last year, I performed more than 10 operation, tracheal operation in China, in other hospitals. In Australia, nowadays, because I stay so longer this time, I know thoracic surgery, especially tracheal surgery in Australia, is not on the top level of this world.
So you'll be able to help?
Yes, I think I can transfer my technique to them. I still like to do some experimental work. That's, I think, easier. If they have a clinical case, I can give them some consultation. I can give them transfer my technique to them. If they need me, I can give them more help. I can do some cooperative work, even free work, no money. Just for that, I feel I still have a value for others, for other countries, for this world. For I still can save people's life. I still have the ability to improve patient life quality. That's enough for me.
Zhao's artificial trachea, is that the most important thing you've done medically?
Yes, I believe that, because that is the only one can heal biologically artificial trachea all over the world, and up to now, no other one.
How will it change the way people look at that sort of medical science? Will it change medicine? Will people take it on in future years?
That's a good question. Trachea disease is not a popular disease. An artificial trachea, no commercial value. If you like to earn money, your artificial trachea cannot earn too much money, because only a little patient there. But tracheal disease is a kind of disease. Nowadays, not a real rare. And tracheal obstruction is more and more people suffer from. For example, a lot of patients, because severe disease or emergency situation, need to be into intensive care unit, and need to be ventilation, mechanical ventilation, and need to do thoracotomy. After intubation and the mechanical ventilation, after intubation of trachea, they can happen scar narrow, scar obstruction, and the patient with a very difficult respiratory failure at last can be respiratory failure. And because this operation, tracheal resection is very difficult, so some patients, a lot of patients, just keep this intubation. They don't do operation resect the trachea. Why? Because operation is dangerous. A lot of doctors cannot do this operation. I believe a lot of surgeons never do this operation in his life. So there, the obstruction of or narrow of trachea, this kind of patient cannot be treated properly. Some with endoscope method, use laser, use cryotherapy, but only for a smaller disease. A severe case had time to work. And eventually, more and more, much severe, the last patient suffocated. So I can do this. And some patients, because this intubation, this tracheotomy, and the upper trachea totally obstructed and cannot speak anymore. I do this operation and the patient can speak again, live a normal life. So I think trachea surgery should be developed fastly, not like many years before. And of course, dangerous. Doctors should not be always think about dangers, some difficult case. Doctors should be say patient is the most important purpose.
Great way to end it. Dr. Jhao Fengrui,
Yeah.
thanks for joining us on Over the Bonnet.
You're welcome.
This podcast is brought to you by Merrimark Medical. Merrimark Medical is your local medical practice in Gympie, specialising in quality family medical care. Are you always sick? Ranging from acute medical issues to management of long-term chronic conditions. When you need to get better, even if you have complex health problems, get the right diagnosis with Merrimark Medical. Contact Merrimark Medical in Gympie on 54811 873 or find them at 18 Young Street. The podcast is also brought to you by Gympie Foam and Rubber, your local store that specialises in foam cut to size. They've got all sorts of good stuff like upholstery and craft foam, even loose fitting foam. The shop is packed with things like mattresses and pillows. Not so squeezy. Now, they'll help you get down and dirty and save your feet with rubber flooring and mats, anti-fatigue matting, and they have industrial mats and rubber. If they don't have it, Andrew will get it in for you. Plus, for Over the Bonnet listeners, mention the show and ask for your discount, and you'll receive 10% off the price. That's right, 10%. Only for Over the Bonnet listeners when you mention the show, and you have to ask for your discount. That's at Gympie Foam and Rubber. And finally, the show is brought to you by Nikat Earth Moving, that specialises in roadworks, house pads, site cleanups, land clearing, dam construction, even dewatering and swamp drainage. I didn't even know you could do that. They have a 140H grader, which is big, and their PosiTrack Bobcat is also huge. There's a D65 dozer, 3 excavators for hire, including a 20-tonne, 8-tonne and a 2.5-tonne. Plus, they provide side truck hire and even have a roller and a water truck. So contact Carl Dakin at Nikat Earth Moving on 0488 228806 and the earth will move for you.